Melanoma will come up more than once or twice, even during this morning session. Dr. William Robinson is a professor of hematology and oncology at the University of Colorado. The introductions in detail are in your programs. The paragraph that you'll see in your program is much more impressive than "Here's Bill."
I thank the GoldLab for inviting me, and I thank Dr. Copeland for an introduction to my talk. I couldn't have written the introduction better had I done it myself. So thanks to Dr. Copeland. What I'm going to tell you is about malignant melanoma, and you're going to see that the molecularly targeted therapy in malignant melanoma has had some dramatic benefits in this disease. But we have moved on to the questioners in the audience here to immunotherapy when we don't give a damn how many mutations you've got or what kind of mutations they are. With immunotherapy of the modern kind, we get even more dramatic results. Now that's in melanoma, and I emphasize that. So I don't know, we don't know what's going to happen in other cancers, but at least in melanoma, the new immunotherapies, can you switch this to the green for me? I thought the red would be better. You can? Yeah. So in 1990, at the American Society of Clinical Oncology, Dr. George Canellis, who was the president of the American Society of Clinical Oncology, was going through the advances that have been made in various cancers for that year. And when he came to melanoma, he said, melanoma is the tumor that gives cancer a bad name, because every therapy we tried other than cutting it out didn't work. Chemo didn't work, radiation didn't work, nonspecific immunotherapy didn't work. And what I'm going to show you is what's happened over the next 20 years had made melanoma the unlikely poster child for the future of cancer and personalized medicine. This is a quote from the New England Journal of Medicine in 2010. Now, what's changed in melanoma during those 10 years? One is a better understanding of molecular changes like Dr. Copeland went through that develop in clinical melanoma. And secondly, the understanding of how melanoma cells evade immune surveillance. And I'll tell you about that, but the way they evade immune surveillance is by making programmed death signals that block anything that comes in to try and kill the melanoma cell. And so we have developed therapies to overcome that. Now, why has melanoma led the change in this whole business? It's because we were driven to this. Melanoma didn't respond to the usual cancer treatments, radiation and chemotherapy. We tried them over and over and over and over again, all different combinations, and continuing with those approaches was the very definition of insanity. Do the same thing over and over again, expect a different result next time. I'll show you a little bit about that. We also knew that sometimes melanoma spontaneously regressed without treatment. I'll show you an example of that. So we knew that there was some kind of immunologic something or another going on. We didn't clearly understand that, but we knew it occurred. And that led us often to look for immunologic therapies in this disease, mostly nonspecific, and almost all did not work. But it was clear that we needed to understand why melanoma didn't respond and why it sometimes regressed. And let me just show you a couple of very quick slides, and I'm not going to belabor all of these, but you'll see more of these as we go along, about melanoma and its treatment with nonspecific immunotherapy. We use vaccines, we use alpha interferon, we use gamma interferon, we use beta interferon, and nothing works. So here's survival curves right here of patients with metastatic melanoma treated with multi-drug chemotherapy with and without various kinds of immunotherapy, and you can see they didn't work. Most people dead out here at 2.5 years, with median survival, so less than 1 year. We'll come back to it a little bit about that. We also knew, as I said, there were spontaneous regressions of melanoma. There are many of these. We see one of these every year. Patient walks in, you see them with metastatic melanoma. They go back to the farm in eastern Colorado with a chest full of tumor, and then they come back in and it's gone, and you say, was that x-ray really this guy? Let's go down and look at it again. But here's one, this is from 2014 in Europe. Here's a gentleman that comes in, so I just saw this one, so I bought it, with multiple areas of metastatic melanoma in the leg. He comes back in 3 months later with no treatment, and the melanomas regress. Not an uncommon phenomenon. Now I'm going to show you what melanoma is briefly, and I'm going to show you what the melanocytes are and why they're so difficult to treat when they develop into melanoma. It's a cancer of the melanocytes, the pigment cells that give your skin its color. It's caused by intense sun exposure in childhood. You go outdoors when you're a little kid, you get fair skin, you get sunburned, you mutate a stem cell in your skin, and that's the initiator, where you get a single mutation that we're going to target later on in BRAF, which Dr. Copeland already talked about. And then when you go out in the sun as an adult and get high-dose intermittent exposure, that's the promoter of the disease. So the initiator in childhood, no doubt about it, I'll show you that, and the promoter is the intermittent high-dose exposure in adults. So I'll show you examples of that. I went the wrong way. Now, the incidence of melanoma was dramatically increased in the United States of America. This is incidence of the disease from 1970 to 2010. Actually, it's up here right now in 2015. This is the number of cases per 100,000. Interestingly enough, changing habits hadn't changed that. So down at the bottom is the introduction of sunscreens of various kinds, and the rising incidence of melanoma is correlated with the use of sunscreens. I could go into a lot of detail about that, but I won't at the moment. But it's now, in terms of the incidence, it's now the fifth most common cancer in males and the seventh most common cancer in females, and continues to rise. We have a very large population of melanoma cases at the University of Colorado. We see 10 to 15 new cases every week, and these aren't the little thin melanomas. These are largely advanced melanomas. We have a big tumor bank with 3,000 annotated specimens. We have plasma serum RNA, DNA, and I put this up here as advertisement. If anybody is interested in specimens, we like people to use them. So we've got them, and you can get a hold of me, and we'd be glad to supply you with these if you're interested. We're currently doing whole genome sequencing with matched normal DNA in 1,000 patients. Now, who develops melanoma? It's the people in this audience. The Caucasians with a high indoor occupations, not the outdoor workers. History of sunburn in childhood, high-dose intermittent sun in adulthood, brown hair, blue eyes, fair skin. There's kind of misconception it's the redhead. It is not. I'm not going to go into detail about that, and a high level of education. The number one, I'll come to it in just a minute. So here's the evidence about childhood exposure. This is the incidence of melanoma in British Isles migrants to Australia and how long they lived in Australia. So I set the incidence of melanoma in Australian-born there and lived there their whole life. Remember, Australia is a very predominantly white population. If you migrate to Australia from the British Isles at age 5 or before, you have the same or slightly higher incidence than if you were born in Australia. If you migrate to Australia when you're 10 years old, higher incidence than the native born. But if you migrate to Australia when you're 20 years old, you have the same incidence of melanoma as if you lived in Ireland your whole life. So it is this high-dose intermittent exposure in childhood that is the initiator of the disease. And it is in high-dose intermittent exposure in adults that promotes the disease. So here's 500 patients in our clinic just walking through the door by occupation, and I could show you this same data from Australia or New Zealand or Germany. Professionals, number one on the list. In fact, attorney is the most common occupation. There are some people that said it couldn't happen to a nicer bunch, but I would never say that. And then as you move down the list, you'll see down here, outdoor workers have the lowest incidence. Complex epidemiology about that, I'm not going to go into it, but it's not because they're largely Hispanic in Colorado. It has to do with how they cover up. Now, what are the melanocytes briefly? And we'll get into all this treatment in just a minute. This is what the skin looks like, the epithelial layer here. And underneath the epithelium sit the melanocytes. They look like octopi or octopus, whatever the plural is. And every epithelial cell, entire epithelial system in your body is connected to a melanocyte. They're derived from the nervous system embryologically, and they squirt, if you will, melanin up into the epithelial layer that gives your skin its basal color. And when you go out in the sun, they put more up there, and you develop a suntan. They are not dividing in the adult, and they are designed not to die. And the reason for that is you have to have them down there. So if you walk in as an adult, as we frequently do, if I do a full thickness skin graft to some other part of your body, and I cut the skin off all the way down to the melanocytes to put on your arm from your leg, it doesn't repigment. The melanocytes do not grow into that area. They're non-dividing. They are designed not to die. Don't die if you get ultraviolet radiation. Don't die if they radiate you with something else. Don't die if they give you chemotherapy. Don't die, period. And that has led to the understanding of how to induce the death in these cells when melanoma develops. Now, in childhood, the melanocyte stem cells are up the epidermis, and as the skin is expanding, what happens is, go back for a second. As the skin is expanding, I went all the way back to the beginning. As the skin is expanding, they move down underneath the skin and sit down here. But the first hit in the development of melanoma is in these melanocyte stem cells in childhood. And that first hit is in the BRAF gene. And here's what happens. And again, Dr. Copeland went through this in how it's done in his transposon method. But what happens is you go from a benign nevus or mole to a dysplastic nevus it begins to grow sideways, it goes down, and then you have metastatic malignant melanoma. And the first hit is in this gene, BRAF, and every mole on your body, if I stand anybody up, we take the mole off, we'll find a V600E mutation in every acquired mole. Now, everything that's brown on your skin is not a mole, however. And then you get increasing mutations, loss of P16, blah, blah, blah. We're not going to go into all of those, but as you go along, you get increasing likelihood of spread of this until you get metastatic malignant melanoma. Now, what we're going to target, and again, Dr. Copeland mentioned this, we're going to target the initiator gene down here, and you'll see that that's very interesting, quite effective. One last point, people always ask me, isn't this increase in melanoma just better diagnosis? People weren't diagnosed 20 years ago, 30 years ago, not a chance. You don't diagnose melanoma, you die of melanoma. So here is a Here's a patient that lived out in eastern Colorado on a farm, had this thing came in, we took a picture of it, he didn't want it taken off, and he comes back 4 or 5 months later with this thing, and then eventually this. This guy had a little melanoma on the tip of his finger, shown here. He had a severe psychotic disorder, didn't want us to cut his finger off, and then came in with this, carried in a King Soopers bag, wrapped with duct tape, and here's his brain scan with multiple areas of involvement there. Now, the survival of melanoma by stage in 2004, and we're going to concentrate on stage 4 disease. That means the disease has spread outside the lymph nodes and past the skin. And the survival in 2004 was essentially nobody was alive out here at 15 years, and the median survival was about 2.5 years. Even with very thin melanomas, 10 to 15% of people were dead in 15 years. And if you had regional lymph nodes involved, 75% were dead. Now, this again is the chemotherapy. This is intense chemotherapy. This is the University of Colorado data, and I'm not going to go into the details about this, but these are patients who are untreated. These are patients that are treated with a very intense chemotherapy regimen, made no difference in survival whatsoever. Now, as I mentioned, the BRAF mutation was found early on to be present in melanoma first, and then back to the moles. And BRAF mutation is BRAF, the protein sits right here, and what normally happens in cell regulation is some growth factor attaches to a receptor here. The receptor becomes phosphorylates this gene, this protein, until you come down and tell the cell to do something. In melanoma, what happens is when BRAF is mutated, it's phosphorylated without any signal from up here. So normally it's like a pinball machine. You activate the receptor, and then bing, 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 phosphorylate everything downstream. But in melanoma, when this gene is mutated, it's just phosphorylated without any upstream involvement, because the ATP binding site swung open. And now what you're going to see is we're going to make a compound that's going to block that phosphorylation site in melanoma. So here's a normal cell signal, just like I showed it. Normally you get an upstream signal, BRAF signals downstream, you get normal cell growth. But in BRAF mutated melanoma cells, and in some other cancers as well, you don't need an upstream signal. BRAF is phosphorylated and just continually stimulates the cells to grow. So what was then done was to make a large number of compounds which were then tested that might fit into or block the ATP binding site in BRAF. And one of these is called vemurafenib. By the way, as you see these new medicines come out, new therapies come out, if it's a nib on the end of it or an ib on the end of it, that means that it's a small molecular, molecularly targeted therapy. If it's a NAB, it's an antibody. You'll see that. So these are the initial studies done with vemurafenib, oral compound, take it twice a day, and it blocks the mutated BRAF. So there's a series of patients at day 15 before and after the vemurafenib. These are PET scans. So the patient is standing facing us like this, and anything black on this scan other than the brain right here in the urinary bladder is cancer. So here's a metastatic lesion here, another one here, the liver's full of tumor, here's one down here, etc. 15 days later, with 2 pills a day, gone. Here's another patient, multiple lung metastases, 15 days later comes in, gone on scan, and gone clinically. Another patient, look at this one with all of these bony metastases everywhere, and comes back 15 days later, largely gone. Here's a gentleman, he comes in, one of the very early patients treated, and now he has all the actual melanomas on his back, and these are all subcutaneous metastases on his abdomen. Treated with vemurafenib. This is 15 days later, comes back. And the patient call you up and say, you know the pills they gave me, that made everything go away. And he comes back. This is about a month later, and now it's all back. So the problem with the targeted therapies in our hands, back to Dr. Copeland's points, there are multiple mutations, thousands of mutations, and we can get significant benefit by targeting one, but we've gone on to target others, and I won't go into that, but with the targeted therapy so far, we keep being stymied. We get another remission, then we'll get another remission, and then we'll get another remission. And the question is, how can we get around this? And yeah. Yeah, these are almost exactly in the identical places that they were before, but also new ones. If you take a patient like this and you look at it, compare here to here, you find some new tumors, some back, and some are totally gone. So we have actually taken tumors out here that have come back compared with tumors over here and looking to see what the mutational spectrum is in those. So here's this, despite the dramatic response, survival with BRAF inhibitors alone remains poor. So these are patients treated with chemotherapy in the initial trials with advanced melanoma compared to patients treated with a BRAF inhibitor, and you can see they do better, but eventually they all relapse and die. So summary of this targeted therapy, it's consistently effective in melanoma patients who have a BRAF mutation, dramatic but short-lived responses. Side effects are limited. Side effects of these pills are you get a skin rash, a little bit of fatigue, but the side effects are small. And there are lots of other mutations, and then the question becomes, what do we do? So let's look at the new immunotherapies for melanoma. Now, in some cancers, the immunotherapies directly affect the cancer itself. And that's most true in the lymphomas in the drug which is called rituximab, which binds to the lymphoma cells, and then your body gets rid of them. In melanoma, we are not going to target the melanoma cells directly. We're going to target the death receptors that the death ligands that the melanoma cells produce to block the immune response. And then the immune system itself, your own immune system, does its work. So there are two of these I'm going to concentrate on. This one, PD-1 programmed death receptor. There's this method as well, and we have two different antibodies to work on these. High response rate, limited side effects, but a lot of questions, you'll see. Now, I meant to point out as I went along that the vemurafenib, the BRAF inhibitor, you can buy it at Walgreens if you've got enough money and a doctor's prescription and a good insurance plan. But for 1 year of that costs about $100,000, right around $100,000. If we add the next one in, which is a MEK inhibitor, I won't go into that, then that's another $100,000. So they're not cheap. So the new immunotherapies, again, don't directly kill, they act on the immune system. So let me point how they work for just a minute. So normally, if you have a cancer cell, it's putting into the circulation tumor-related antigens, which then go to an antigen presenting cell, presents it to a T cell, part of the immune system. This T cell comes in and kills the cancer cell. That's what you're supposed to do. Now, what happens in melanoma is the antigens secreted, they go up here, But the T cell has on it these PD, programmed death receptors. And what the programmed death receptors are for is when you want to get rid of the immune response. If you have an infection or something, you have to get rid of that activated immune response to your infection or to your little skin cancer, but whatever it might be. And what the melanoma cells do is to make a ligand that binds to the receptor and it blocks it from being activated. So the T cells are stunned and even killed in melanoma. So now the immunotherapy we're going to use is directed against this. And this is one of these. Novolumab is the name of the antibody. Now let's look and see what happens. Given IV, because it's a protein, it's an antibody, have to give it IV, given IV every 3 weeks. I'll talk about the side effect. Here's an example of a patient treated. Again, this is a PET scan. Brain up here is black. We're looking for black otherwise. Black, melanoma, melanoma. 12 weeks later, this is after 4 doses, everything is gone. 24 weeks later, it remains all gone. And now, 30 weeks back, retreat the patient. And oftentimes with these immunotherapies, the patients will have some remaining disease like here and here that you can see on the scan, but they're clinically fine. But we continue to treat at the present time. Here's one from the New England Journal of Medicine. I'm going to show you very quickly because it just is last week's. So this is combining 2 immunotherapies, an anti-PD-1 and an anti-CTLA-4. We're looking at this patient up towards her chest. This is a big neglected malignant melanoma right here. Sideways on a CT scan, it's this thing right here. She got one IV dose of 2 of these antibodies, and 3 weeks later, it's totally gone. She got a hole in her chest where the melanoma was, but we can take care of that. Now here is a comparison of, and the only reason I want to show you this, I want to show the combination, which is what that woman just got. A comparison of an anti-PD-1 antibody given every 2 weeks and an anti-CTLA-4 antibody given every 3 weeks, and the PD-1 antibody is a little bit better. But when we combine them together, this is from the New England Journal of Medicine, again a couple of weeks ago, when you combine an anti-PD-1 and an anti-CTLA-4, and that really unleashed the immune system, you can see out here, at least at 18 months, that the majority of the people are alive. And that is regardless of the molecular spectrum of their individual melanoma. Now, how long is this going to last? We don't have any idea. And every patient asks you when they come in, doctor, how much longer do I have to take this damn treatment? I have to come in here every 3 weeks and have to get this in my vein, and we don't know the answer to that. What we are doing is we give it every 3 weeks for 1 year, and then we go to every 4 weeks, and then we go to every 6 weeks. But is that going to work? I don't know. I'm not going to go into that one. So the summary for advanced melanoma, summary for immunotherapy for advanced melanoma, significant benefit with few side effects. I didn't go into those, but sometimes when you unleash the immune system in other areas, you can get colitis and other autoimmune problems. Disadvantage have to be given IV, have to be given every 3 weeks, no clear-cut data on how long we have to give them, and for now, they're continuous every 3 weeks. I didn't put the cost up here. Again, you can get these, not at Walgreens, you actually have to go to a clinic to get these, about $120,000 a year for each of these individually. Most insurance companies will pay for them. So the overall summary of what I want to tell you about melanoma, it's gone from a cancer which has been totally unresponsive to most therapy to one in which these new molecular targeted therapies and immunotherapy have changed our view of melanoma. And By the way, they've changed our view of cancer therapy in general. Now everybody wants our treatments. One of these anti-PD-1 antibodies has been approved for lung cancer recently. And we're now doing current studies combining these two approaches, that is, combining the targeted therapy and the immunotherapy, and we don't have any data. They literally started last week. So I'll stop there and see if there are any questions.
A lot of that stuff is not trivial. That's for sure. Let's start right there.
So, Dr. Robinson, you showed a couple really provocative slides, and then you said they were too complicated, and you just went on, and I don't think that's fair in this audience.
That's right, okay.
So the two questions...
New England Journal of Medicine last week, you can find.
Oh, okay, so the two questions I had was, you showed the sunscreen correlated with the rise in cancer, which maybe is actually related to the hole in the ozone, I don't know. And then you showed the outdoor workers not getting as much skin cancer, and I'm trying to figure out what, and you also showed that weird graph with the peak at 9 years old, and I'm trying to figure out whether to tell my 8-year-old son that he should never put sunblock on and spend at least an hour outside every day for the rest of his life.
So the thinking about the increased use of sunscreens, but the continuing rise of melanoma, is that when you use sunscreens, you think you're bulletproof, and you spend a lot more time in the sun and get a lot more sun exposure than you thought you were going to get. For your 8-year-old son, the important thing is to protect him as much as you possibly can, because that's when you do the damage. Now, my recommendation is to use sun-smart suits rather than use the sunscreens, is to really use clothing that protects them. Because when they're little, they hate the damn sun. You got it in my eyes, kind of thing. And so you put the suits on, and that's how I devise them. Yeah, but they need protection. I don't care about the adults, so you've already screwed yourselves.
Yes, sir.
Enjoyed your presentation. Can you comment on the nature of the immune response that in patients with vitiligo allows them to survive much better spontaneously when a melanoma comes up when compared to those that don't have vitiligo? What neoantigens, what immune response is spontaneously active there?
So the question is, if you don't know what vitiligo is, you see people have these autoimmune patches of white skin, and they can have it. It rises spontaneously. It was said to be what the reason that Michael Jackson's skin turned white. I will tell you that the anti-PD-1 and ipilimumab antibodies do not induce vitiligo. They don't in some way affect normal melanocytes. Now, some of the other prior immune therapies we use, like vaccines, did induce vitiligo, but these agents, it's not a factor. But with the other immunotherapies, particularly with interleukin-2 and some of the vaccines we used previously, of which there were low response rates, the development of vitiligo predicted response to the immunotherapy, but not in these.
Are there unique neoantigens in vitiligo patients that drive that response?
Yeah, I can't answer that. I have not worked in that particular area. I know others have.
We're going to, in the interest of preserving your break, Dr. Robinson, are you leaving right now, or are you going to be around for a little while?
No, I'm going to stay on.
Okay, one more question before we break. Dr. Joyner, do you have a question?
There's a lot of enthusiasm for these various targeted therapies, and I wonder if either you or Dr. Copeland could comment on the use of surrogate markers like clinical response or progression-free survival versus overall survival, and whether or not people might be getting a kind of false sense of optimism based on the either clinical response or progression-free survival data.
Like what kind of surrogate markers were you thinking?
In other words, instead of looking for looking for an overall survival effect like you showed, drugs are now getting approved on the basis of progression-free survival
Oh,
or
yes,
clinical
yeah.
response. There's a big debate in the oncology community about whether it's meaningful or just simply measurable.
Yeah, I can't comment on those. I will tell you that the trend at the moment for looking at how we measure response other than scans and physical examination is using cell-free DNA circulating. So for BRAF, we can measure the mutated V600E DNA circulating, not cells, but circulating DNA. And one can show that the copy number goes down, down, down with therapy, and before the patient relapses on the scan, you can see the cell-free DNA coming up. If that's a surrogate marker, I don't know exactly. It's a tumor marker of some kind.
Thank you, Dr. Robinson.